Thank you all for coming. So today we will have our center-sponsored student fellows to present their ongoing work. We have three presenters. The first one is Lingzhi Chu from the Department of Environmental Health Sciences. She will be talking about the temperature and renal disease hospitalization in Vietnam. And followed by Lingzhi will be Phoebe Tran from the Department of Chronic Disease Epidemiology. She will be talking about cardiovascular disease and focusing on US. And last but not least will be Yiqun Ma, also from the Department of Environmental Health Sciences. She will be talking about how to conduct disease burden type analysis in Jiangsu Province, China. Each of the presenter will have 15 minutes to present, and at the end we will have a 15 minutes Q&A section. As a reminder, this seminar is being recorded and will be available on our center website. So without further ado, I think I can hand it over to Lingzhi.
Can you all see the screen? Okay. Hello, everyone. I'm Lingzhi. I'm now a third-year PhD student in the Department of Environmental Health Sciences, working on climate change, air pollution, and kidney disease. Today, I will talk about a project in progress, ambient temperature and renal disease hospitalization in Vietnam. Under a warming climate, we may see an expanding heat belt in this century. Extreme heat will very likely occur more often, last longer, and become more intense, which is a potential risk factor for a heavier health burden, especially among children and the elderly. Therefore, relationships between high ambient temperature and human health are becoming the focus of research. My research focuses on renal disease, which is a prevalent non-communicable disease, although the exact links with ambient temperature exposures have not been demonstrated comprehensively. Some biological mechanisms have been proposed. The mechanisms are mainly framed around heat injury and dehydration. Under exposure to high ambient temperature, increased sweating will lead to internal dehydration, which will on one hand lead to decreased glomerular filtration rate and potentially cause acute kidney injury, and will on the other hand stimulate the secretion of vasopressin. Vasopressin is a hormone that can increase blood pressure and increase water reabsorption. Therefore, the increased vasopressin levels can cause tubular damage through glomerular hypertension and then lead to chronic kidney disease. Furthermore, increased water reabsorption caused by vasopressin secretion leads to smaller volume of concentrated urea, and then potentially cause urolithiasis, as known as kidney stone, and chronic kidney injury. Also, repeated chronic kidney injury will lead to new onset of chronic kidney disease or make existing chronic kidney disease more severe. In terms of epi-evidence, previous studies have indicated non-weak or relatively strong harmful relationships between high ambient temperature and renal disease. In renal disease specific analysis, existing evidence has suggested stronger effects of high temperature on acute renal disease and urolithiasis compared with other renal diseases. Overall, there is insufficient research on high ambient temperature. Also, previous studies were usually conducted in countries like the United States, Australia, South Korea, and China. No studies on ambient temperature and renal disease risk have been conducted in Vietnam, which is ranked among the top 10 countries most affected by climate change. Therefore, the aim of my study is to examine short-term associations between high ambient temperature and risk of hospital admissions for different renal disease outcomes in Vietnam. In this study, we obtained daily individual admission records from 14 provinces and cities in Vietnam and extracted records on 4 main health outcomes based on ICD-10 codes: glomerular disease, renal tubular interstitial disease, chronic kidney disease, and urolithiasis. In order to comprehensively describe the effects from ambient temperature, we evaluated 4 different temperature metrics: daily maximum, mean, and minimum temperature, and daily heat index, which is calculated by daily mean temperature and daily mean relative humidity. Also, since we focused on high ambient temperature, we restricted the study period to warm seasons. We designed a case crossover study to evaluate the short-term effects. With the case crossover design, patients included in this study serve as their own controls. For example, if someone is admitted into hospital for renal disease today, then the case date is today, and the temperature today would be the exposure for the case. And then we picked days 1 and 2 weeks before and after today to be control days. The temperature exposures at these 4 days would be the exposure for the controls. The 1 case and the 4 controls would be considered as one matched set. Conditional logistic regression models will then be fitted to estimate the effects of ambient temperature on renal disease outcomes. Since the cases serve as their own controls, individual characteristics like age and sex are controlled automatically in this study design. Taking potential heterogeneous effects in different provinces, we conducted a 2-stage analysis. We first modeled the province-specific associations and then put them together to obtain the overall estimates using random effects meta-analysis. In models, we adjusted relative humidity for daily mean, maximum, and minimum temperature, since humidity is a very important weather factor that will affect the field temperature. Furthermore, in order to evaluate potential additional effects from extreme heat, we defined the days with daily maximum temperature to be at least the 95th percentile as extreme heat days. Currently, the time window of the temperature associated with renal disease is still unknown. Therefore, we first evaluated single legs from leg 0 to leg 14 and cumulative exposures from leg 01 to leg 06 using moving averages in separate models for the 4 different temperature metrics and the 4 different health outcomes, respectively. We then determined the optimal metrics among the 4 temperature metrics and the main leg structure for each outcome based on the magnitude of the associations. On the other hand, for the extreme heat to bring additional effects, it has to have some independent effects first. Therefore, we evaluated extreme heat independently in models first. Here, we defined the cumulative exposure to extreme heat by counting the extreme heat days over lag periods. For example, the count of extreme heat days at lag 0 can be either 0 or 1, and the count of extreme heat days at lag 0, 1 can be either 0, 1, or 2. If the extreme heat has independent effects on specific outcomes, we determine the main lag structure for it. The next step is to evaluate the additional effects from extreme heat besides the effects of ambient temperature by putting them together into the same model. Lastly, we evaluated the effect modification by age and region. Here are the main results. In the first step regarding the pure ambient temperature model without extreme heat, here I took daily mean temperature and urinalysis as an example. Daily mean temperature showed the strongest association compared with other metrics and was therefore considered as the optimal temperature metrics for urinalysis. The left panel of the figure shows the effect according to single legs from leg 0 to leg 14. We can see that the effects increase until leg 5 and decrease to nearly the none at leg 7 or leg 8. The right panel shows the effects according to cumulative exposure from leg 0, 1 to leg 0, 6. As mentioned before, we use the moving average of temperature here. For example, exposure at leg 0, 1 is the average of exposure at leg 0 and the exposure at leg 1. We can see the effects keep increasing within 1 week. Since we know from the left panel that the effects after leg 7 is nearly none, we determined leg 0,6 to be the main leg structure of the associations between daily mean temperature and urinalysis. Here, we found that the magnitude of associations associated with daily mean and minimum temperature for urinalysis were very similar. So we just kept both mean and minimum temperature for urinalysis here. And the main leg structure regarding minimum temperature and urinalysis is also leg 0,6. Similar with previous interpretation, we picked daily minimum temperature at leg 0,4 for chronic kidney disease, daily minimum temperature at leg 0,6 for glomerular diseases, and daily maximum temperature at leg 0,6 for renal tubular interstitial disease. Then in the second step, we fitted models with count of extreme heat days only. The x-axis here is from leg 0 to leg 0,6. For urinalysis, the main leg of extreme heat is leg 0, which means the same day effects played the main role. We did not find significant independent effects of extreme heat on chronic kidney disease. For both glomerular disease and renal tubular disease, leg 0, 1 is the main leg. Then we put the optimal ambient temperature metrics and the extreme heat variable into the same model for the outcomes, except chronic kidney disease, because we did not find significant independent effects of extreme heat for chronic kidney disease. We found that the count of extreme heat days was not significant anymore in the models with ambient temperature, indicating no additional effects from extreme heat. Also, the point estimate of ambient temperature did not change much compared with the pure ambient temperature model. Therefore, we determined the ambient temperature model without extreme heat to be the optimal models for all the 4 outcomes. We then used the optimal models for the 4 outcomes to examine the effect modification. We did not see significant heterogeneity between northern and southern regions. Also, there is no heterogeneity across age groups in our study. In summary, we found that short-term exposure to higher ambient temperature is associated with increased risk of the 4 renal disease outcomes, while the optimal temperature metric and the main time window are different. Exposure to extreme heat days does not add to risk, besides the effects of ambient temperature. We still have some limitations in this study. For example, no information on admission types, exposure misclassification due to latency between symptom onset and hospital admissions, potential selection bias due to including provincial hospitals only, and no data on acute renal disease. In a word, still many things to do, but this is a good start to explore the differentiated response of different kidney disease outcomes to ambient temperature. That's all. Thank you.
Well, thank you, Lingzhi, for keeping on time. And just a reminder to everyone, if you do have a question, please put your question in the chat box, and we will have the time at the end to answer them. So next, let's turn the stage to Phoebe.
Okay. Okay, today I'll be talking about the impact of temperature on US cardiovascular disease, hospitalization, and mortality. Okay, so the topics that I'll be covering in this talk include background information, on stroke and acute myocardial infarction. These are the two cardiovascular conditions that are the focus of the pilot study. Then I'll discuss why we're interested in looking at the relationship between temperature and cardiovascular disease and how this relates to our pilot study. Okay. Give me a second. I'm having some issues with my Zoom.
If you want to just pass on to the next slides, you can just use the on your keyboard.
I'm having some issues removing because my bar is blocking my slides.
I think it's relatively okay. It's not that big, so we can.
Oh no, I can't see my slides. Okay. So there are two main types of stroke. Approximately 87% of strokes that occur are ischemic, with hemorrhagic strokes making up the remaining 13%. Ischemic strokes occur when a clot forms in the blood vessel that transports oxygen to the brain, while a hemorrhagic stroke is what we term a brain bleed, and these occur when a blood vessel bursts and bleeds into the brain. Acute myocardial infarction, AMI, these are also known as heart attacks. AMIs occur when blood flow to the heart becomes disrupted, and as a result, the heart doesn't receive adequate oxygen and thus cannot function properly. There are shared risk factors for stroke and AMI. They include factors that are modifiable, such as hypertension, diabetes, as well as factors that cannot be modified, such as increased age, being 65 and older, as well as belonging to a certain racial/ethnic group. For example, we see higher rates of cardiovascular disease among African Americans. So I'll briefly touch on the current burden of stroke and AMI globally as well as in the United States. So approximately 13.6 million strokes and 7.3 million AMIs occur annually. And this makes stroke and ischemic heart disease, which includes AMI, the second and leading causes of death worldwide. So around 11% of global deaths are stroke-related and 16% are ischemic heart disease related. In the United States, more than 796,000 strokes occur annually, and this makes stroke the fifth leading cause of death among Americans. For AMI, more than 805,000 AMIs occur annually in the US, and it's a leading cause of death in this country. So the burden of stroke and AMI is not distributed uniformly throughout the United States. We see geographic variation in US hospitalization and mortality for stroke and AMI. In the top figures here, I have stroke hospitalization on the left, stroke mortality on the right, and the bottom figures, AMI hospitalization on the left and AMI mortality on the right. We can see in all four of these maps, there's higher rates in the southeastern portion of the United States. And this is an area known as the stroke belt, where there have been higher rates of CVD for many decades, and it's a pattern that we continue to see to this day. So how does this relate to the future burden of cardiovascular disease in the United States? If we look at this figure, we can see that in the coming decades, more and more Americans will become 65 and older. As I mentioned previously, those who are 65 and older have an elevated risk of having a stroke or AMI. And so with an increasingly aging population, this leads to increasing incidence of stroke and AMI in the US, and thus increasing total costs of CVD here in the US. And total cost includes both hospitalization and medication costs, as well as days of missed productivity when an individual is too ill to work after having a stroke or AMI. So in 2020, the total US CVD cost was around $700 billion. And this figure is predicted to rise to nearly 1.1 trillion by 2030. So that's a rather large jump there. So temperature has emerged as a potential factor in cardiovascular disease research due to its involvement in multiple pathophysiological cardiovascular disease pathways. This is still an active, ongoing area of research, but scientists have hypothesized several mechanisms linking temperature with CVD. So first, with daily temperature fluctuations, this can lead to increased sympathetic nervous system activity, as well as increased systemic inflammation. And these are two processes that can increase an individual's risk of having either a stroke or AMI, especially if they already have existing CVD risk factors. Additionally, with rapid temperature fluctuations, this can lead to disruptions in regulation of blood pressure, blood viscosity, as well as blood coagulation, which can also increase an individual's risk of having a CVD event. So climate change has led to more frequent extreme weather globally, as well as in the United States, which we saw recently here with the winter storms in Texas. And as a result, this has increased attention towards the influence of daily temperature fluctuations on stroke and AMI. And when I'm talking about daily temperature fluctuations here, I'm specifically referring to daily temperature range. So as a result, there have been a number of studies on associations between daily temperature fluctuations and daily temperature range on CVD hospitalizations and mortality. And this includes some absolutely wonderful work from YCCCH EHS faculty, Dr. Kai Chen, who studies in Europe and Asia, have linked extreme heat with increased cardiovascular disease hospitalization and mortality. So even with the existing literature that we have on daily temperature range in cardiovascular disease, there's still some gaps in the literature that warrant additional focus. The first is that we see inconsistent results from the studies that we do have. Additionally, there's little available US research. Much of the research that we have in this area comes from Europe, the Middle East, or Asia, and this can lead to issues of generalizability when comparing study findings. And one of the reasons as to why we have such little available US research is because of a lack of a national surveillance system for stroke and AMI in the US. This is in contrast to other chronic diseases such as cancer, where we have national registries where diagnoses are regularly collected. However, we can work around not having a national surveillance system for stroke and AMI by making use of large administrative data sets as a resource. And that's exactly what we did with Medicare for the pilot study that we conducted. So with the gaps in the existing literature on daily temperature range and cardiovascular disease in mind, we had two specific objectives for our pilot study. We first wanted to examine how daily temperature range influences hospitalization and 30-day all-cause mortality for stroke and AMI in Medicare beneficiaries throughout the United States. Additionally, we wanted to assess these relationships at the national and regional level while adjusting for season and patient demographics. And this pilot study was made possible through a generous pilot grant from the Yale Climate Change and Health Initiative, and results from the study were presented at the 2021 International Stroke Conference. So the study population for our pilot study consisted of 2014, 2015 Medicare data. This included fee-for-service beneficiaries who were 65 and older. Medicare is the largest US health insurance program. It covers 47.8 million people who are 65 and older, with the majority of them participating in the traditional fee-for-service plan, around 70% of them. For our study outcomes, we were interested in looking at 30-day hospitalizations for ischemic stroke and acute myocardial infarction, and these were identified using ICD-9 codes. We were also interested in assessing 30-day all-cause mortality within our study population. Okay. We obtained information on patient-level characteristics. This included age, sex, race, and comorbid condition/medical history. And these characteristics were identified from Medicare data files. For temperature, we found daily temperature data from the National Centers for Environmental Information, and we used this to calculate daily temperature range. So that would be the maximum temperature on a given day minus the minimum temperature on that same day. We determined in which geographic region a hospitalization or mortality occurred in, and we used the National Oceanic and Atmospheric Administration's 8 climate regions. For analyses, we created a Poisson model to examine the relationship between daily temperature range and 30-day hospitalizations while adjusting for season and patient demographics. A logistic regression model was used to assess 30-day all-cause mortality, adjusting for season, patient demographics, and clinical characteristics. And we assessed these relationships overall, so at the national level, and also within the 8 NOAA climate regions. All analyses were conducted using SAS version 9.4. So for results, we had 311,213 unique stroke hospitalizations. The stroke hospitalization rate was 735 hospitalizations per 100,000 beneficiary years. Among stroke patients, their mean age was 78.8. They were 53% women and 84% white. And 30-day all-cause mortality among stroke patients was observed to be 12%. We had 274,703 unique AMI hospitalizations. The AMI hospitalization rate was 639 hospitalizations per 100,000 beneficiary years. And among AMI patients, their mean age was 77.6. They were 45.4% women and 86% white. And 38-day all-cause mortality among AMI patients was around 12.8%, so similar to stroke. So this figure here shows the relationship between each 1 degree Fahrenheit increase in daily temperature range and ischemic stroke and acute myocardial infarction hospitalization. And we observed that for each 1 degree Fahrenheit increase in daily temperature range, there was a corresponding 1.26% increase in ischemic stroke hospitalization and a 1.48% increase in AMI hospitalization. These associations varied regionally, but were seen to be strongest in the northwestern part of the US and smallest in the east-north central portion of the country. This figure here shows the relationship between each 1 degree Fahrenheit increase in daily temperature range and ischemic stroke and AMI mortality. And in contrast to what we saw with hospitalization, there was little association between daily temperature range and mortality. Both of these associations were 1. So there are a few limitations to our study that need to be considered. There may be some misclassification when using ICD-9 codes to identify ischemic stroke and AMI. However, validation studies have shown that the sensitivity of these codes is quite high, between 85 and 90%. We could only include people who were 65 and older. However, the majority of strokes in AMI occur in this age group, and people who are 65 and older make up 64% of stroke and 71% of AMI hospitalization. Additionally, there may be some issues regarding the accuracy of ICD-9 codes to identify the comorbidities that we adjusted for. However, the positive predictive values of most of the comorbidities that were adjusted for were between 67 and 95.6%. So in conclusion, daily temperature fluctuations are associated with increased stroke and AMI hospitalization. Associations were not seen for mortality. For future directions, we're interested in further exploring reasons for regional variation in associations, as well as looking more closely into vascular event prevention efforts for vulnerable populations. So that would be for individuals who already have existing CVD risk factors who live in areas that see high temperature variability. So I'd like to thank the collaborators and support for the study, from PI, Dr. Jude Lickman, members of her research group, Dr. Erica Leifheit, Dr. Yun Wang, collaborators from the University of Kentucky, Dr. Larry Goldstein, and I also want to highlight the research support that we received from the study. So once again, a huge thank you to the Yale Climate Change and Health Initiative for their pilot grant program, as well as the funding that we received from the National Institute on Aging. Reference for the study, and I'll be happy to take any questions that you might have later.
Wonderful. Thank you, Phoebe. So let's turn the page to Yiqun, and let's shift the focus from now US to China.
Okay, hello everyone. Today, let me share a study on the burden of cause-specific mortality attributable to heat and cold. It's a multi-city time series study in Jiangsu Province, China. The adverse effects of extreme heat and cold on human health have been reported by a lot of studies. It has been reported that non-optimum air temperature, in other words, heat and cold, contributed to nearly 8% of total mortality. Based on a crude literature review, we found most previous studies have examined all-cause mortality, or mortality of a few major categories of health outcomes, such as cardiovascular and respiratory diseases. However, other categories, such as mental and nervous disorders, genitourinary and digestive diseases, and external causes, got limited attention. In addition, the results are quite inconsistent in terms of the effect on mortality risk of infectious and endocrine diseases. Therefore, this study aims to first systematically identify plausible causes of death associated with temperature from a comprehensive spectrum, and then quantify the corresponding mortality burdens attributable to heat and cold. We collected time series daily data from 2014 to 2017 for 11 cities in Jiangsu Province, China, with a total population of over 70 million people. Daily cause-specific mortality data were obtained from the death register system from the CDC and were extracted according to ICD-10. More than 1 million cases of deaths were included in the study. The meteorological data were obtained from the China Meteorological Data Sharing System, including air temperature, relative humidity, precipitation, air pressure, and sunshine hour. We also collected air pollution data from the National Air Pollution Monitoring System. Here is an overview of the statistical methods. In the first stage, we conducted a standard time series quasi-Poisson regression separately in each city to estimate the city-specific temperature mortality associations. Then, in the second stage, we used a univariate meta-analysis to get the province-level temperature mortality associations and to derive the best linear unbiased prediction loop for the overall cumulative exposure-response relationship. Then, based on the bloop, we calculated the minimum mortality temperature, MMT, set this temperature as reference, and estimate the cumulative relative risk and mortality attributable to heat and cold. Here, let me show more details about the two stages used to estimate the temperature mortality associations. In the first stage, because the health effects of temperature are often nonlinear and delayed in time, the distributed lag nonlinear model, DLNM, was used in this study. The DLNM can describe the additional dimensions of lag exposure and lag response relationships, simultaneously representing the nonlinear temperature mortality associations and the lagged effect. Here is the mean model. Temperature is characterized by a cross-basis term based on the DLNM, representing both temperature response and the lag response effect. The exposure response relationship was fitted by a quadratic B-spline with 5 degrees of freedom. And for the lag response, there were 3 internal knots, and we used a maximum lag of 21 days to include the long delay of cold effect. Secondly, the seasonality and the long-term trend was controlled by a natural cubic spline over the range of study dates with 7 DF per year. TOW is an indicator of day of week. And we also controlled for relative humidity, RH, by a natural cubic spline function. In the second stage, a univariate random effect meta-analysis was used to pool the city-specific risk estimates for each outcome. The fitted meta-analysis models were then used to first construct the overall cumulative exposure response curves for all cities, and secondly, to derive the best linear unbiased prediction bloop in each city. Bloop presents a trade-off between the location-specific association provided by the first stage analysis and the pooled association derived from the meta-analysis. Bloop is quite useful. For example, in some cities with small daily mortality counts or a short study period, the estimates we got in the first stage can be very imprecise. Then Bloop can borrow the information from a larger population that share similar characteristics to get a better city-level estimates. Then the minimum mortality temperature, MMT, the temperature corresponding to the lowest mortality, was derived from Bloop in each city, and we set them as the reference temperature. The quadratic B-spline function of the temperature mortality association was then recentered with the MMT of each city. Okay, after we estimated the temperature mortality curves for those outcomes significantly associated with extreme heat or cold, we calculated the cause-specific mortality counts and fractions attributable to non-optimum temperature by these two formulas. This method was well established in a previous study, so I won't go into details today. Then let's see the mean results. This table shows the descriptive statistics on study period, study population, daily mortality counts, and meteorological factors in the 11 cities. As you can see, besides each major categories, we also focus on some specific outcomes of interest, such as diabetes, Alzheimer's disease and dementia, COPD, and suicide. For the cardiovascular diseases, we look at the 3 main subgroups: ischemic heart disease, IHD, stroke, and hypertensive diseases, and also myocardial infarction, MI, under IHD, and hypertensive disease, heart disease, HHD, under hypertensive diseases. For air temperature and relative humidity, they are generally similar in each city. This figure shows the overall cumulative temperature mortality associations in all cities. It's the pool estimates for each outcome. There are 19 outcomes, but let me first use the figure of all-cause mortality to explain all the components. The x-axis is temperature and the y-axis is relative risk. This curve is the temperature mortality association. Blue represents cold effect and red represents heat effect. And the gray area is the confidence interval. The gray line in the middle is the minimum mortality temperature MMT for each outcome. And the dashed lines on the left and the right are the 2.5 and the 97.5 percentiles of temperature distribution. And we report RR at these two temperatures. This page and the next show the curves for all outcomes. We found extreme temperature not only associated with cardiovascular and respiratory diseases, but also diseases of other systems and some specific disease of interest. As we can see in this page, both extreme heat and cold have statistically significant effect on all-cause and CVD mortality, and the mortality of nervous system and Alzheimer's disease and dementia. Endocrine, diabetes, and mental mortality were only significantly associated with extreme heat. In this page, we can see subtypes of CVD, including IHD, MI, stroke, hypertensive disease, HHD, and respiratory diseases, including COPD and external cause mortality. These diseases were all significantly associated with both extreme heat and cold. Then, after the relative risk, we also calculated the attributable burden. This table shows the attributable fraction of cause-specific mortality associated with heat and cold. 11.98, about 12% of all-cause mortality was associated with non-optimum temperature. When we look at the contribution from heat and cold separately, we can see cold contributed most to HHD and COPD mortality, while heat contributed most to mortality from Alzheimer's disease and dementia. In this table, the denominator is the total mortality count for each specific cause. And we also use the total mortality from all causes as the denominator to calculate the proportion of heat and cold related deaths in total mortality. The results were shown in the table on the left. And for the figure on the right, we only present the fractions of the lowest level of studied causes in each disease system. In this tree map, the whole rectangle is all-cause mortality. The blue and red are the mortality attributable to cold and heat, and the green part is the mortality not related to temperature. And the gray part is diseases for other systems. From this figure, we can easily see that temperature-related stroke and COPD mortality contributed most to the total mortality. In the figure, in the table on the left, let's focus on the 6 specific diseases: diabetes, MI, stroke, HHD, COPD, and Alzheimer's disease and dementia. The temperature-related deaths from these 6 specific diseases contributed about 8% of the total mortality. And if we regard the temperature-related all-cause mortality, the 11.98% as a whole, it contributed about 2/3 of the total temperature-related mortality. Okay, I know there's a lot of causes, numbers, fractions. So let me briefly summarize the main findings. We observed that both extreme heat and cold were significantly associated with increased mortality risks of multiple subtypes of cardiovascular diseases, respiratory diseases, nervous disorders, and external causes. The results also showed that mortality risks of endocrine system and mental disorders were sensitive to extreme heat. These are the causes of death that we found to be sensitive to temperature. And for the attributable burden, in total, we found about 12% of total mortality was attributable to non-optimum temperatures, among which about 8% was attributable to Alzheimer's disease and dementia, MI, stroke, HHD, COPD, and diabetes. These findings suggest the potential threat of death from several understudied diseases brought by extreme temperature, especially for vulnerable population, such as patients who already have these diseases. In addition, we want to highlight that the most temperature-sensitive diseases were not the diseases leading to the most mortality counts attributable to non-optimum temperatures. For example, stroke was neither the most sensitive disease to extreme heat. In other words, the RR for stroke is not very high. And it's also not the disease with the most fraction attributable to heat. However, because of the high prevalence of stroke, heat-related stroke mortality contributed most to the total mortality compared with the proportions of heat-related mortality from other causes. This indicates that the prevalence of diseases plays an important role in the estimation of temperature-related cause-specific mortality burden in total mortality. Okay, that's all, and thank you for listening.
Great. So thanks, our three speakers. And just a reminder, if you do have any questions, please type in your question in the chat box, and we will have them answered. So before then, we do have some questions already collected from the seminar students. I will just read some of them, and for each speaker specifically. So a lot of questions has been given to Yiqun's presentation. For example, there's one question regarding the methodology you used, the MMT, and the question is, you defined the setting the MMT between some like 2.5% and 97.5%, that range, and they are wondering if temperature goes above the 2.5% and 97.5% of the daily average temperature, do you somehow take into that extreme temperature into account in your calculation?
Yes, so for MMT, I found the MMT between the first and 99% percentile of the temperature distribution, because at the two extreme, the sample size are relatively low. So I don't want that to influence the choice of MMT. And for extreme temperature, I define them as the as lower than 2.5 percentile and above the 97.5 percentile. And I report the RR at these two temperatures. So in the calculation, these two extremes are considered and included for the attributable fractions.
Okay, great. Another question actually, it's actually a question for three of you, because we have wonderful representation from three different regions. So the question is, the question is whether your regions or country-specific data can be externally generalizable to other locations. So maybe Phoebe and Lingzhi and Yiqun then.
Yeah, I can go first. So I think in the case of the United States, I don't think we can actually like generalize it to a lot of many other countries because of the how specific our healthcare system is. There's a lot of other countries where these studies have been conducted before. They have universal healthcare or a healthcare system where it's easier for people to get access to cardiovascular care should they need it. So I think that that's why we need specific countries for certain areas.
Yeah, I think the results based on Vietnam may be it may be also difficult to generalize to other areas because in terms of temperature exposure, maybe the heat adaptation of the local population will have some effects on the final risk from temperature. And also regarding kidney disease, the occupational exposure to heat is very important. For example, in hot regions with agriculture industry to be the main primary industry, then the occupational exposure to heat due to agriculture workings may play the main role, but this could not be true in other regions.
Yes, I agree. And also there are some large-scale study like multi-country, multi-city studies. And we can see from their results, the estimated curves for different regions can be at least slightly different. So usually it's difficult to simply generalize the findings from region-specific study to other regions. And therefore, like large-scale studies covering more regions and countries are very valuable and necessary.
Great. We actually have a question from the audience similar to the previous question regarding whether about the consistency of the findings regarding your conclusions from the previous literature. So Lingzhi, yeah, go first.
Yeah, currently there are some evidence regarding temperature and kidney disease, but as I mentioned, the evidence is divergent. So some shows the non-association, some even show protective effects. But since that the study in Vietnam is even sparse, so it is hard to compare with other studies in other regions.
Okay, if there's no question, then another question from the student is actually some of you also mentioned the importance of air pollution in studying the temperature effect. So the question is, could air pollution possibly play a role in the increased mortality or morbidity that you observed during the extreme heat and cold time periods? Yeah, maybe Lingzhi first and then Yiqun.
I think it is possible, but we haven't done that yet because yeah, we are not sure whether, for example, the local weather condition will affect the local air pollution and then lead to the change of health impacts. But I think it is really an interesting point that we should consider ambient temperature and air pollution together. And also, I think the interactions between these two factors are really important. But currently, the regarding kidney disease, the evidence on air pollution is very limited.
Yes, I also agree that air pollution can play a great role in the association between temperature and mortality. And in our study, we in the sensitivity analysis, we included PM 2.5 and other air pollutants into the model as a confounder to see its impact on our results, and the results were consistent with the mean model. But I definitely agree that there are more to explore about the role of air temperature, like the interactive effects with temperature or other issues.
I agree as well with including air pollution. So this was just an exploratory analysis, but it's definitely something that we're considering in the future, especially since there have been studies that have documented connections between air pollution and pathophysiological mechanisms of CVD. So definitely in the future.
So great. So I think as a lot of questions are actually very related to what we are currently doing. For example, the interaction studies, both in Lingzhi's and Yiqun's future research plans, they're a key part. I do have another question from the audience asking, are there any current investigations to reduce mortality burdens due to the extreme heat or cold? So it's kind of similar question from the students are kind of wondering, are there any policy recommendations that you can generate from the studies, or any specific interventions that you can have for recommendation?
I know that in some regions, it is requested to provide sufficient water and sufficient provide sufficient time for the workers to have a rest. And also in some areas, it is recommended that they have somewhere with air conditioning for the workers to take a rest.
Yes, I agree. Like, in addition to those policies, I also heard that there are like white roof programs in New York City, at least under study, and also like more green area, more parks, and water area in the city.
Yes, I think it's important. So I know that we have like specific alerts on days when there's high temperature, and I know there's like a push towards having more like areas where people can go to get cooler, like just public areas on hot days. So I think that now that there's more of a recognition of the impact of temperature on, that can go a long way towards help informing policy.
As a reminder to the audience who has not actually watching our YCCH seminar before, we do have a speaker in the fourth semester, Dr. Gregory Williams from the Boston University. He talked about a lot of policy implication intervention measures that can actually help reduce the heat health effects. So if you're interested in this type of research, please feel free to go to our YCCH website and to look at the recording of that lecture. I think we have all the questions answered, and if there's no more questions, I would like to thank the three students for presenting their fantastic work. And as always, I think I speak for the whole YCCH. We're very proud of your work. And hopefully, and thank you for all the audience to come today, and wish you enjoy the sunny day.